My name is Rodrigo Stein. I'm the Director of Health Equity and Strategic Community Partnerships at La Clínica del Pueblo. The Department of Health Equity and Strategic Community Partnerships has basically two major functions: reducing barriers associated to the social determinants associated with immigration as a social determinant of health, and reducing barriers for medical care relating to language barriers. So we facilitate medical interpretation services for patients needing specialty care. La Clínica consistently has promoted the idea that immigration is a social determinant of health, and as such, it requires a multi-layer approach to address this, including how we approach diabetes care. Because immigration status affects a person's abilities to gain meaningful employment. It affects a person's ability to obtain health insurance, whether that's employer-sponsored or publicly and subsidized healthcare. La Clínica's approach recognizes these barriers and works to address them by strengthening multisectoral partnerships that address the barriers that are visible and tangible with immigration, such as facilitating food access, facilitating referrals for legal organizations, addressing and facilitating or minimizing some of the barriers associated with immigration, as well as this network of medical interpretation when engaging with specialty care. My primary function is to strengthen those intersectoral partnerships, whether it's legal, food access, so they understand the barriers that some of our communities face, whether that's a partner having language access services on site or facilitating interpretation service, specifically when we speak about the legal, whether through our food access partners, that they understand that not all of our community will be eligible for SNAP or WIC benefits due to their immigration status. These partnerships have to be mindful of these barriers, and we have to create joint solutions. I believe that one of the ways that COVID transformed the organization was developing more intentional protocols and processes of how to be able to do remote work. For example, I know for the diabetes management classes, these were all done in person, transition to facilitating 6-week to 8-week behavior change classes over Zoom, over existing remote technologies, required a lot of protocol development, also a lot of training on behalf of patients. A lot of our patients are older, limited English proficient, so a lot of these technologies, unfortunately, are not easy to come by and explain in simple language in Spanish. So it took a lot of effort from the health educators to explain people how to facilitate the internet tools available. In the early stages of COVID, we did transition for La Clínica to become a food distribution hub, something that was never done before. So we recognized the immediate material need, and thanks to our strong partner, our strong network of food assistance partners, La Clínica absorbed the responsibility of, in the early stages of the pandemic, also becoming a food distribution site specifically for patients at risk or living with diabetes. For immigrant communities, if jurisdictions don't recognize or don't allow for public funded options or exclusion through the type of employment that access to insurance, I think organizations that work with immigrant communities should be on the policy front, examining what options exist at the county or state level to guarantee access to care. On the other front, partnership building and addressing the immediate and material social needs, such as food, but not only any type of food. Healthy and culturally appropriate food that recognizes the community is also an important step. And from that social need, build the case that, you will address something immediate. That is not a long-term solution. So what policy changes have to change are at the bigger level. We're talking about wages, we're talking about worker protection, we're talking about long-term immigration reform that has to, for the Latino community, especially the immigrant Latino community, and more specifically low-income Latino immigrant community. Those are the systemic changes that need to be pursued. Well, we've been successful to eliminate one of the barriers for the DC Alliance. We've been able to successfully push a recertification period to a year, matching the Medicaid recertification process. However, that is still incomplete, even though we're very grateful for the effort and our partner coalition's work. However, the Alliance is still not comparable to Medicaid since it doesn't cover services such as mental health. And I know when we speak about health, we define it as the complete social, mental, and physical sense of well-being, not only physiological response. So I think in integrating mental health will be very important as a next step for our advocacy with the DC Alliance. Because we are in multiple jurisdictions, not only in the District of Columbia, we work in Prince George's County in Maryland, seeking, as I said before, county or state solutions within the state of Maryland that can increase access to high quality and culturally appropriate healthcare for immigrant communities. So whether that is pursuing unique county funding or to create a similar insurance program such as the Alliance, or whether that's actually going at the state level